Hi, everyone. My name is Siddharth Prakash. I'm a clinical cardiologist and geneticist at the University of Texas Health Science Center at Houston. And I'm talking today about exercise risk in patients with aneurysms and dissections. Some questions that my patients ask me about exercise in clinic are, I have an aortic aneurysm. How can I remain active and live a productive and healthy life? What exercises do you recommend for people who are at risk for aortic dissections? And after surgical repair of my aorta, what activity levels may be appropriate? To answer these questions, I will share some information that we use to assess our patients and some information that might help you prepare for living an active and healthy life. First, the overall question about what your personal risk to have a vascular dissection must take into account several factors. We know that all patients who have heritable thoracic aortic disease or another genetic mutation that may predispose you are at risk, but the risk is not proportionally distributed among all people. We know that there are risk factors like having high blood pressure, the type of genetic mutation that you have, which you may have been counseled about by your physician, whether or not you've had previous aortic surgery, and pregnancy can all increase a person's risk to have a dissection at particular times in your life. So these things must be accounted for when we make a plan for exercise. So how safe do we know that exercise is for patients who have aortic disease? Well, there have been several studies that showed that moderate exercise is valid for patients who've had abdominal aortic aneurysms and may even decrease their rate of expansion. We know that patients who have undergone cardiac rehabilitation exercises after thoracic aortic repair appear to do well and that this is safe in 3 different studies. And finally, more recently, in mice with Marfan syndrome gene mutations, we know that moderate exercise actually slows down the rate at which their aorta enlarges and may help to prevent dissections. Taken together, all of these studies show that exercise is safe and may actually be therapeutic for patients with aortic disease if done under appropriately controlled circumstances. On the flip side, we know that many dissection survivors had been engaged in vigorous physical activities immediately prior to dissection. The most prominent of these may be weightlifting or other types of isometric exercises, which we'll get into later. We know that the intensity, acuity, and dynamic component of exercise may differentiate what is beneficial from what is harmful and what may trigger dissections. Therefore, the type of exercise that you wish to engage in also affects your risk. And of course, uncontrolled high blood pressure is the #1 risk factor for aortic dissection. So it is really important to get that under control and be on preventative medical therapies before you start exercise. The reason for this is that the pounding of your pulse that you may feel during exercise actually reflects the distension of blood vessels. And this occurs not only in your wrist where you may feel your pulse, but also in the aorta. And this increased pressure puts stress on the aortic wall. If you already have an aneurysm or you have a thin aortic wall from genetic disease or high blood pressure, this further increases the risk for distension, enlargement of your aneurysm, or dissection. And again, we know that there are risk factors, some of which we can measure to give us a better indication of the risk. So what is the most important thing before exercise? You need to know and control your blood pressure. We recommend for patients with Marfan syndrome and related disorders that their resting blood pressure be less than 130 systolic over 80 diastolic. And this can change over time, as I mentioned. So it's important to keep track of your blood pressure and make sure it's treated if it is hot. So the other thing to do and to know is the status of your aortic disease. This requires lifelong follow-up, as most of you know, that all children and adults with heritable vascular diseases require lifelong surveillance. This can run anywhere from annual checkups with your primary care physician to regular blood pressure checks and medication adjustments. So it's important to have regular individualized checkups for your aortic disease and know what it is before you embark on an exercise program. In terms of blood pressure, since it's the #1 risk factor, we spend a lot of time making sure our patients do not have high blood pressure. And it turns out that blood pressure we measure in the office reflects only about 2/3 of the actual load of blood pressure that people experience. We know that there are effects of being in the clinic called white coat effects, where the blood pressure may be elevated for people when they show up in our office, but normal at home. And on the flip side, we know that many people who show up with normal blood pressures in the clinic actually have high blood pressures at home. So we're missing or misdiagnosing a substantial amount of hypertension if we simply rely on office blood pressures. So this is where ambulatory blood pressure comes in. We know that your blood pressure over the course of 24 hours does not remain constant, but has normal variation, peaks and valleys that can influence your individual risk for dissection. This has to do with the time of day, how active you are, when you take your medications, and other disease-related factors that are very individual. So it's hard to predict just from a single blood pressure measurement. So in particular, when you go to sleep at night, your blood pressure should drop, but we know that in some people with vascular disease, including aneurysms, this doesn't happen, and the blood pressure may actually rise. We wouldn't detect this unless we were measuring this through the full 24 hours. So this shows an example of a 24-hour blood pressure measurement in one of our clinic patients. And what we're looking at here is on the long axis, the hours of the day from 12 p.m. on day 1 to 12 p.m. on day 2, reflecting 24 hours of blood pressure measurements. Each dot on the graph is the time in which blood pressure was taken. And on the vertical axis, you can see the blood pressure measurements. This patient has significant hypertension, as indicated by the red line, which is the systolic blood pressure, being above 140 for most of the day. But as you can see at night, the blood pressure drops to normal levels before rising again the next morning. Therefore, this is stage 1 hypertension with a blood pressure between 140 and 160 most of the time, with intact nocturnal dipping, that drop in blood pressure at night. In contrast, this patient has the opposite problem. You can see that during the day, from 9 a.m. to roughly 9 p.m., their blood pressures are largely within the normal range. But in that purple shaded area at night, their blood pressures rise quite dramatically and become quite hypertensive. This is called reverse dipping. So instead of dropping, as I mentioned, their blood pressure would abnormally rise at night. And this can reflect other kinds of pathology like sleep apnea that we often need to investigate and can control successfully with minimal interventions. And we know that when this type of blood pressure pattern happens, patients may be at risk for aortic dissection at night. Here's a case in which a patient has normal resting blood pressure, but in times when they're active, as indicated by the gray squiggly lines on the horizontal part of the graph, their blood pressure surges with exercise. So this is exertional high blood pressure with otherwise normal features. And you can see that in many patients with aortic disease, their blood pressure may be normal at rest, but elevated at exercise. And in those patients, we often do additional tests to show that exercise may be safe for them before we permit them to do a full exercise program. So if we diagnose hypertension, regardless of the method, we do recommend that it's treated with 2 main types of medications, beta blockers on the left and angiotensin receptor blockers like losartan on the right. An example of a beta blocker would be metoprolol, and the mechanisms of action are different. Metoprolol slows the heart rate and decreases the sympathetic drive of the nervous system. This is appropriate in most patients because it actually protects the root of the aorta and ascending the best, and that is what is most often affected in thoracic aortic disease. Whereas angiotensin receptor blockers function by a different mechanism, lowering the blood pressure throughout the body and also reducing the amount of fluid retention. It's important to know that most people who had dissections with or without exercise were actually not taking adequate doses of their blood pressure medication. So once again, visiting with your doctor and working with them to establish the proper dose is essential before you start exercise. We also know that the risk of exercise is associated with whether there's dynamic or isometric exercise, because the pattern of rise of the blood pressure is quite different. On the left, I'm showing you a dynamic or aerobic exercise in which someone is running. And during that time, you can generally see a gentle rise in systolic blood pressure with virtually no change in the diastolic pressure that levels off and eventually decreases as soon as you stop. However, with isometric exercises, we know that blood pressure can increase quite dramatically. This shows the classic example of weightlifting. And in actual fact, it's not a smooth rise, but it's more like a squiggle, where with each repetition, blood pressure will peak relatively quickly and drop off just as quickly when the effort is relaxed. So this kind of rapid alteration in blood pressure is actually even more deleterious because it causes an increased rate of strain on those blood vessels that we were talking about. And not to mention the fact that the absolute value of the blood pressure increases is quite a bit greater than with aerobic exercise. In isometric exercises, the increases in blood pressure are sudden and short-lived. They're very difficult to measure because of the fact that you're doing a Valsalva and holding your breath during isometric exercise. There's a lot of variability depending on the technique and the training that you have. And there's a limited opportunity to adjust the intensity of exercises before you reach that critical threshold of very high blood pressure that we would be concerned about as a dissection risk. Whereas aerobic exercises have a more predictable and gradual increase that can be more readily measured during exercise, as I will show you. And this provides us an opportunity to adjust the intensity of exercise to reduce your risk of dissection. This is data from our clinic showing the changes in systolic on top and diastolic on bottom blood pressure for a variety of different exercises that are written across the bottom. Leg raises, hand grips, bicycles, bicep curls, and a wall sit, in which you pin your back against the wall with legs roughly parallel. As you notice, the leg raise and the wall sit have the most dramatic changes in systolic and diastolic blood pressure. And this is because they're isometric exercises where you're not moving, but maintaining contraction. Whereas bicycle has a relatively minimal change in diastolic blood pressure and a relatively smaller change in systolic blood pressure. So this illustrates, again, the difference between the types of exercise. And we think that it makes it more reasonable for us to consider dynamic or aerobic exercises in our patients as a first method when we're starting an exercise program. And the other important long-term effect of aerobic but not isometric exercises in data from our group is that with training, the exertional blood pressure can actually drop in aerobic exercise, but not in isometric exercise. This shows the graph of patients who claimed different levels of moderate activity per week. And you can see that on the right, for those who had more moderate activity each week, up to 400 minutes, their maximum blood pressure during bicycling was significantly lower than those who had minimal moderate activity per week. Whereas the numbers are not particularly consistent for the wall sit and isometric exercise. Therefore, training is also possible to reduce your risk if you start with a relatively low amount per week and gradually increase your capacity. We also know that blood pressure peaks during exercise are associated with risk. This graph shows treadmill exercise, a common form of cardiovascular risk assessment. If your blood pressure remained less than 150, your risk of dying from cardiovascular disease over the subsequent 20 years is almost twice as low as if your blood pressure increased to more than 160 millimeters. And this is during a regular, relatively moderate stage 2 treadmill exercise, which would not be anything close to maximum or vigorous activity. So there is significant predictive value in becoming hypertensive during exercise, and we can do something about it, as I'll show you. We put our patients on the treadmill, and this is an example of two profiles that we often see. So patient 1 has normal resting blood pressure and heart rate, but as soon as they get on the treadmill, you can see that the blood pressure on the right there in the red box dramatically increases up to 225 millimeters of mercury, almost twice the resting blood pressure, and remains elevated well into recovery after exercise. Whereas patient 2 on the bottom has a relatively higher baseline blood pressure with baseline stage 2 hypertension that peaks early, plateaus, and actually decreases with exercise. So compared to patient 1, patient 2 would actually be at lower risk, but you wouldn't know that from their baseline blood pressures. So therefore, exercise blood pressure response is not predictable from baseline blood pressure, which is important to know when we're trying to risk stratify our patients. We also check something called vascular stiffness using a type of blood pressure cuff called a sphygmocore. This is something that we can do in clinic because it also shows that a predictive value for determining which patients may be at risk in the future for high blood pressure or aortic events. And this device works by extrapolating the aortic or central blood pressure that the blood vessels actually experience from the peripheral waveform by measuring in different wave reflections from the periphery to the center. It's called arterial waveform analysis, and it will allow us to risk stratify our patients more than just the regular cuff blood pressure does alone. So this shows an example of two patients in our own clinic who had different central aortic pressure profiles. In patient one, we have a 53-year-old man with vascular EDS who had no previous dissections. You can see that his arterial pressure waveform is relatively normal. It shows two peaks, an early shoulder of the forward wave from the heart, and then a higher peak of the reflected wave. He has a normal profile, and with relatively normal central aortic pressure, we would call this a normal aortic stiffness study. Whereas this 26-year-old woman with multiple previous dissections actually shows the opposite problem. She has what's called significant augmentation, a peak causing excessive force in the central aorta, more than what would be predicted for her age and sex. And this reflects increased stiffness in her vessels, which is a marker for future aortic events. Now, we hope to, by phenotyping more of these patients, even before they have aortic dissections, we can predict which patients may be at risk and then treat them with medications to actually counteract this stiffness effect, measuring the effect by serial approaches. So in summary, we are trying to control all three components of hypertension in order to reduce a person's aortic disease risk. There is the blood pressure we measure in the office, the ambulatory blood pressure that occurs during natural 24-hour variations, and exertional blood pressure, as well as vascular stiffness. The three of these together account for what person's total risk due to high blood pressure. And we have to measure and treat all three of these components in order to improve outcomes in high-risk patients with vascular disease. So what do we tell our patients? We tell them that they can lift whatever weight they can comfortably lift without having to bear down. We don't recommend isometric exercises as a starting point, and we want to try to titrate their risk based on their blood pressure and response to aerobic exercise. We do recommend regular aerobic exercise because, as I showed you, training can reduce the blood pressure response and therefore decrease your risk. We also think that training can reverse some of the aortic stiffness and vascular stiffness that we can measure on the sphygmocore. And what about if patients want to engage in more intensive exercise regimens, like a marathon, or want to do training for an athletic event? How do we manage them? Well, in our clinic, we do a multi-step protocol, which takes into account history and physical and genetic evaluation. That includes the type of mutation they have, their family history of aortic dissection, any contraindications they might have to exercise outside of their heart or blood vessels, like skeletal problems. We do an ECG, we do the sphygmocore waveform analysis to assess their vascular stiffness and for evidence of underlying cardiac disease. We measure baseline hypertension, and we will do a battery of tests, of course, that include imaging to assess their aortic disease. If they wish to engage in vigorous exercise, we put them on the treadmill and measure their aerobic response to exercise, as I showed you, to look for exercise-induced hypertension and to measure activity thresholds above which their blood pressure may increase to dangerous levels. And we also analyze their 24-hour pattern to assess for the reasonable expectations about timing of exercise and whether their medications need to be adjusted. This leads to an exercise prescription that includes targeted anti-hypertensive therapies and a risk reduction strategy of slowly graded exercise over time. We can then reassess this at intervals as they progress in their training to adjust the targets as we need to keep our patients safe and active. Thank you very much.